Okay. So, a very good evening to all of you. How many of you are online? Can you please confirm? Can you please confirm me about audio and video? My audio, video, all clear or not? Audio, video, anyone would like to answer? Yeah. So, Dr. Nirupam, good evening. Dr. Rishabh, a very good evening. Dr. Zainab, good evening. No voice. Okay. Now the voice is clear or not? Dr. Meman, the voice is clear or not? Done. The voice is now clear. Okay, so a very good evening, Dr. Achal. Yes. Okay, thanks. Thanks for the confirmation, doctors. Dr. Jigar, Dr. Snigdha, Dr. Dhanush, Dr. Nirupam, a very good evening. So, we are going to start with this test and discussion of pharmacology. And the first topic is autonomic nervous system. And before that, let me introduce myself. And I am Dr. Saurabh Bhatia. And I have done my graduation and post-graduation both from the Delhi University. And I hope you people are either final year students, interns, and post intern. No one here is from third year and second year. Please confirm if anyone is from second or third year, because test and discussion is mainly for final year students if there is going to be NEET, if there is going to be next, or it's also for intern and post intern students. Okay, so first topic is autonomic nervous system. And in this topic of autonomic nervous system, you must be knowing there are two topics which are mostly asked. The first is the cholinergic drugs. So in the autonomic nervous system, the first topic that is most important topic is cholinergic drugs. So every year you expect one MCQ from cholinergic drugs. Now after the cholinergic drugs, the second topic which is important is alpha blockers. So every year you get one MCQ from alpha blockers. So the very less number of drugs are there in alpha blockers, but the topic is very important. So cholinergic drug topic is important, alpha blocker topic is important. And the third topic which is important here is anti-glaucoma drugs. So anti-glaucoma drugs, alpha blocker, cholinergic drugs, these three topics are very important in ANS. So if you are going for your exam, whether you are going for your INS-CT exam or the NEET PG exam, these are the three topics we expect you at least to read for your last minute revision in pharma, in ANS. Right, so most of the questions are expected from these three topics. Okay, so I'm repeating these three topics. One is the cholinergic drugs, second is the alpha blockers, and the third one is anti-glaucoma drug. This year in your INS-CT exam, there is one question from alpha blocker. So I told you this topic is very important. So this time they have asked the question of prazosin. So scorpion sting case was there, and they asked this question on alpha blocker this year. So alpha blocker, cholinergic drugs, and anti-glaucoma drugs, three topics are important. Now we are going to start with the first MCQ for today. Which of the following receptor associated with IP3 and DAG activity as a secondary messenger? Anyone would like to answer? What is the answer of this question? So which of the following receptor associated with inositol triphosphate and diacylglycerol activity as a secondary messenger? Four options are there in front of you. Nicotine N receptor, muscarinic 2 receptor, muscarinic 3 receptor, muscarinic 4 receptor. Anyone would like to answer? What is the answer? Anyone would like to answer? Dr. Rishabh has answered. It's C, muscarinic 3. Okay, Zainab, Achal, all of you have answered C. So the answer is C only. So if three people have said C, so the answer is going to be C only, M3 receptor. So in this receptor, they have asked you the secondary messenger. So if we talk about the secondary messengers, very good. So Dr. Meman also has answered correctly. It's C. So if we talk about autonomic nervous system receptors, if we talk about receptors of autonomic nervous system, so we know that we have two types of autonomic nerves. We have two types of autonomic nerves. One is known as sympathetic nerves. Second is known as parasympathetic nerves. So we have two types of nerves, sympathetic and parasympathetic nerves. In sympathetic nerve, the neurotransmitter is noradrenaline. In parasympathetic nerves, the neurotransmitter is acetylcholine. So parasympathetic system, the neurotransmitter is acetylcholine. Sympathetic system, the neurotransmitter is noradrenaline. Now if we talk about acetylcholine receptors, if we talk about the receptors of acetylcholine can act on two types of receptor. The first is known as nicotine receptor. The second is known as muscarinic receptor. So acetylcholine can act on two types of receptor, nicotinic and muscarinic receptor. Now if we talk about this nicotine receptor further of two types, nicotine N and nicotine M type. So nicotine receptor is further of two types, nicotine N, nicotine M, right? And muscarinic receptors further of five types, muscarinic 1 to muscarinic 5. Now if we talk about nicotine receptor, now nicotine receptor is a ion gated channel. Nicotine receptor is a ion gated channel and muscarinic receptor is a G protein coupled receptor. So muscarinic receptor is G protein coupled receptor, nicotine receptor is ion gated channel, right? So whenever the nicotine receptor will open up, there is an entry of one ion and that ion is sodium ion. So there are total 7 receptors, 5 muscarinic, 2 nicotine receptor of acetylcholine, right? So please remember all receptors of acetylcholine are stimulatory in nature. All receptors of acetylcholine are stimulatory in nature except 2 muscarinic receptors. Which are not stimulatory. You people have to answer me the name of those 2 receptors which are not stimulatory. So all acetylcholine receptors, whether they are nicotinic or muscarinic, all receptors are stimulatory type of receptor. The symbol of arrow going upwards showing you the stimulatory effect of the receptor. But there are 2 muscarinic receptors which are not stimulatory, rather those receptors are inhibitory. Can any one of you answer which muscarinic receptors are inhibitory? Very good. So Dr. Rishabh and Dr. Achal has answered correctly. Even Zainab has answered correctly. So 2 receptors are muscarinic 2, muscarinic 4. So muscarinic 2 and muscarinic 4 receptors are inhibitory type of receptor. Rest of the receptors are stimulatory in nature. So all these receptors are stimulatory, but muscarinic 2, muscarinic 4 are inhibitory. Now if we talk about nicotine N receptor. Now if we talk about this receptor nicotine N, it has a double N. So double N means wherever we have the nerve and nerve junction. So wherever we have the nerve and nerve junction present in human body, we will find nicotine N receptor. So nicotine N receptor is present wherever we have the nerve and nerve junction, and this nerve and nerve junction is present in autonomic nervous system. The structure is known as ganglia. So we have the nicotine N receptor present at nerve and nerve junction. In autonomic nervous system, this is known as ganglia, and in central nervous system, this is known as nucleus. So in central nervous system, this is known as nucleus. In autonomic nervous system, this is known as ganglia. Now in central nervous system, we have multiple nucleus present, and we have the nicotine N receptor of multiple types present in CNS. But the most important nicotine N receptor, which you people have to remember in respect of your entrance examination, is a alpha 4 beta 2 type of nicotine N receptor. So there is one nucleus of your CNS, right? In that nucleus we have a presence of a receptor, we call it nicotine N receptor. The subtype is alpha 4 beta 2 type. So alpha 4 beta 2 subtype of nicotine N receptor is a most important receptor for your examination, because this is the receptor that is involved in nicotine addiction. So all drugs that you will read useful for nicotine de-addiction, all the medicines that you read that is useful for nicotine de-addiction, they will act on this alpha 4 beta 2 type of receptor. So this is important in respect of that thing, right? So this is important for your exam to know about this receptor, because all the medicines which are useful for nicotine de-addiction will act on this nicotine N receptor in the body, in the CNS, alpha 4 beta 2 type. Now if we talk about nicotine M receptor, now nicotine M receptor is present at neuromuscular junction. So as the name suggests, nicotine M, it's a nicotine receptor present on muscles. We call it nicotine M receptor present in neuromuscular junction. So this receptor is present in neuromuscular junction, and it is present in neuromuscular junction in the present in somatic system. So this receptor belongs to somatic system. Now if we talk about the configuration of this nicotine M receptor, the configuration of this receptor is, this contains 2 alpha 1 chain. This contains 2 chain of alpha 1, 1 beta, 1 gamma and 1 delta. So it contains 1 delta, 1 gamma, right? So 2 alpha, 1 beta, 1 delta, 1 gamma. So if I draw the structure like this way, So the structure of this receptor is like this way. The 5 units are there. There are 5 units present in the structure, right? So the first 2 units are known as alpha 1. So first is alpha 1, then again we have one more alpha 1 over here. But in between 2 alpha 1, we have one beta, and here we have the delta, and here we have the gamma. So we have the alpha 1, beta, alpha 1, delta, and gamma. Now please remember, whenever acetylcholine will act on this receptor, the binding site of acetylcholine is at the junction of AB, that is alpha 1 beta and alpha 1 delta. So students, make the mnemonic like this way: after breakfast, after dinner. So acetylcholine binding site on this receptor are alpha 1 beta interface and alpha 1 delta interface. Alpha 1 beta, alpha 1 delta, these two sites where the acetylcholine will go and bind. Right? Now we have a skeletal muscle relaxants. Skeletal muscle relaxants are blocker of this receptor. So same are the binding site of skeletal muscle relaxants. They will go and block the binding of acetylcholine in a competitive manner. So any medicine that ends with the word curium or curare, these medicines will go and bind to the alpha 1 beta, alpha 1 delta. Mnemonic is after breakfast, after dinner. This is a binding site of skeletal muscle relaxants. So this is all about the nicotine receptor that you should know for your exam. Now if we talk about muscarinic receptor, there are total 5 muscarinic receptor, M1 to M5 receptor. Now please remember, muscarinic 1, muscarinic 3 and muscarinic 5. These 3 receptors are stimulatory type of receptor. They are associated with activity of IP3 DAG. So they are associated with activity of IP3 and DAG, and this IP3 and DAG can increase the level of calcium, and by increasing the level of calcium, this will result in contraction of a cell. So we call them stimulatory type of receptor. Right? So these kind of receptors are mainly present on a structure which has a contractile property. So these are present on the structures which have the contractile property, like they are present on the surface of muscles. So on the surface of smooth muscles, normally you will find muscarinic 3 receptor, but you can also have the other receptors like muscarinic 1 and muscarinic 5. They are also involved in contraction of a cell wherever they are present. The secondary messenger is IP3 DAG. Now here the calcium is also present. This calcium is known as the tertiary messenger. Right? So for most of the receptors, we don't have the tertiary messenger. We have only one tertiary messenger, that is calcium, that is associated with IP3 DAG activity. This is a tertiary messenger. So IP3 DAG are the secondary messenger, but the calcium will act as a tertiary messenger, can result in contraction of the cell. Now muscarinic 2 and muscarinic 4. If I talk about muscarinic 2, muscarinic 4, they are the G protein coupled receptor. We have discussed already. They are the G protein coupled receptor. These two are inhibitory type of receptor. So they will decrease the level of cyclic AMP. So they decrease the level of cyclic AMP in the body and can result in inhibitory actions in the body. Right? So this is all about the acetylcholine receptors, how these receptors will act in the body. Now if we talk about in brief about this other thing, because this question was based on acetylcholine receptor, but the other system is sympathetic system. So we have noradrenaline or adrenaline present in the sympathetic system. They will act on 2 types of receptor, alpha receptor or the beta receptor. Now if we talk about beta receptors are total 3 in number: beta 1, beta 2, beta 3. Now beta 1, beta 2, beta 3, they are the stimulatory type of G protein receptor. So they are the G protein coupled receptor, stimulatory type of receptors. They will increase the level of cyclic AMP. So they will increase the level of cyclic AMP, the beta receptor. But if we talk about the alpha receptor, we have alpha 1, we have alpha 2. So we have alpha 1 receptor, we have alpha 2 receptor. Now can any one of you tell me, out of alpha 1 and alpha 2, which is inhibitory type of receptor? So out of alpha 1, out of alpha 2, out of alpha 1 and alpha 2, which one is inhibitory type of receptor? Anyone would like to answer? Out of alpha 1 and 2, which one is inhibitory type of receptor? Anyone would like to answer? Alpha 1, alpha 2, which is inhibitory? Answer is alpha 2. So alpha 2 receptor is inhibitory type of receptor. Very good for this answer. So this will decrease the level of cyclic AMP. Right? But alpha 1 receptor is again a receptor that will increase the IP3 DAG level. So this will increase the level of IP3 DAG, and with the help of calcium, this will again lead to stimulatory action. Now guys, if we look at the data of the last 10 years exam ka data, if we see, we will find that most of the questions which are asked on the secondary messengers are asked on the ANS receptor. Like whenever they have to ask a question, on the secondary messenger, they always ask a question on the autonomic receptors. So these receptors are important for your exam, autonomic receptors. Now apart from that, we can discuss some other receptors which are asked in your previous exam. For example, they have already asked you about the angiotensin 2 receptor. So we have the angiotensin 2 present in body. So we have the angiotensin 2 present in the body. So what is the name of a angiotensin 2 receptor? So angiotensin 2 receptor is known as the AT1 receptor. So angiotensin 2 receptor is AT1 receptor, and this receptor is also associated with IP3 and DAG activity. So this receptor is asked in one of your previous exams, so this can be repeated again. Similarly, the ADH receptors, antidiuretic hormone receptor. So antidiuretic hormone, which is also known as vasopressin. Now this vasopressin can act on two types of receptor, V1 and V2. Now out of these receptors, V1 receptor is associated with IP3 DAG and can result in vasoconstriction. So this is involved in vasoconstriction. And V2 receptor is associated with cyclic AMP activity and can result in water retention. So this can result in water retention. So this vasopressin receptors are important. The third receptor, they have asked you the serotonin receptors. So if we talk about the serotonin receptors, so all serotonin receptors are G protein coupled receptors. So all serotonin receptors are G protein coupled receptor except one. There is one serotonin receptor which is not a G protein coupled receptor. Now this you people have to answer me. All serotonin receptors are G protein coupled receptor except one receptor which is not G protein, that is a ionic receptor. So there is one receptor which is ionic receptor. All serotonin receptors are G protein coupled receptors. So if I talk about the serotonin receptors, there are total 7 receptors from 1 to 7. Serotonin 1 to serotonin 7 receptors. All receptors are G protein coupled receptors except one which is not a G protein, that's a ionic channel. Who will tell me the name of that receptor, which is the ionic channel? The answer is very good. So the Tanisha has given the answer, serotonin 3 receptor. So serotonin 3 receptor is the one that is a ionic receptor. The rest of the receptors are G protein coupled receptor here. So all serotonin receptors are G protein coupled receptor except the serotonin 3, which is a ionic type of receptor. So these are some important receptors that you should be knowing. The secondary messengers of these receptors can be asked. So in last 10 years, they have asked only these 4. Okay? The last 10 years, they have asked only these 4. Maximum, you can remember one more, histamine. Histamine receptors, they can ask you. So histamine can act on H1 and H2 receptor mainly. H3 is not important, so we'll not discuss. So H1 receptor will increase the level of IP3 and DAG. And H2 receptor will act by increasing the cyclic AMP. So there is no other MCQ in the last 10-year exam. So maximum they have asked only these G protein coupled receptors and how these exactly act in the body they have asked. Right? So this is all about question number 1. If you guys have any doubt, please ask me. If you have any doubt in this question, please ask me. Now let's move on to the question number 2. Now the question number 2 is based on ACLS protocol. So ACLS full form is Advanced Cardiac Life Support. So Advanced Cardiac Life Support Protocol. Now in this ACLS protocol, which other drug is present along with the epinephrine? So epinephrine is there, that we know. So in ACLS protocol, we know that epinephrine is a part of that protocol, right? So epinephrine is given for this type of presentation. We call it pulseless ventricular tachycardia. So patient might come to you with pulseless ventricular tachycardia. So epinephrine is definitely given. Now which other drug can also be there? Who will tell me the answer of question number 2? So apart from epinephrine, which other drug is there in the ACLS protocol? So in the ACLS protocol, ACLS full form is Advanced Cardiac Life Support Protocol. Apart from epinephrine, which other drug is also there? Can anyone answer this question? Answer is very good. So the answer is bolus dose of amiodarone. So we have a bolus dose of amiodarone. So this is the answer of that question. So amiodarone is the drug that is there in this protocol of ACLS. So here in this MCQ, we can discuss the ACLS protocols. So if we talk about this ACLS protocols, yes, Dr. Harsimran has given the answer. So I'm discussing question number 2. Answer is D, Delhi. So if we talk about this ACLS protocol, so we can divide these protocols in 3 categories for the pharmacological point of view. So for pharma subjects, we can divide in 3 categories. Number 1, the protocol for tachycardia. So patient can come to you with life-threatening tachycardia. Patient can come to you with cardiac arrest. So patient can come to you with cardiac arrest, and patient can come to you with life-threatening bradycardia. So patient can come to you with tachycardia, patient can come to you with bradycardia. Now, whenever the patient has come to you with bradycardia, who will tell me the drug of choice over here? Which medicine will I give? Which medicine is the best medicine for bradycardia? Anyone? So which medicine is given as a best medicine for bradycardia? Anyone would like to answer? Yes, so on the YouTube, there is one Next PG Trivia. Next PG Trivia, it's better if you come up with your original name, because by this way, it's difficult to pronounce such a long name. So anyone would like to answer? What is the best medicine for bradycardia? So the best medicine for bradycardia that you can start in this ACLS protocol is? No one is there to answer? No problem at all. I will help you out. Very good. So Dr. Harsimran has given the answer. Rishabh has given the answer. Zeel has given the answer, correct answer. So Nimish, Zainab, all of you have given the correct answer. The drug name is atropine. So atropine is a drug that is given for the treatment of bradycardia. So this is a basic question that you should be knowing. Now after knowing this atropine, the answer of bradycardia, you should be knowing the starting dose. Now what is the starting dose of atropine here? The starting dose of atropine is 1 milligram. So starting dose of atropine is 1 milligram, and the maximum dose which I can give to this patient is 3 milligram. So in a one go, I cannot give beyond 3 milligram. So the starting dose of atropine is 1 milligram, and the maximum I can give to the patient 3 milligram in a one go. I cannot go any dose beyond 3 milligram. And as a student, as an intern student, or as a clinician, I would say you should be knowing 1 ampule of atropine. 1 ampule of atropine that is available in your cardiac care unit or cardiac ICU. 1 ampule of atropine contains how much of drug? So the answer is 1 ampule of atropine contains 0.6 milligram of drug. So 1 ampule of atropine contains 0.6 milligram of drug. So in this way, I can say maximum you can give 5 ampules to a patient for the treatment of bradycardia. So the starting dose is 1 milligram, maximum dose is 3 milligram. 1 ampule of atropine contains 0.6 milligram. Maximum you can give 5 ampules to this patient for the treatment of bradycardia. Now after the atropine, if the patient disease is not controlled. So after giving atropine, if the patient disease is not controlled, then you have 2 more options that you can give. So either you can give dopamine. So you can give dopamine, or you can also give adrenaline. So adrenaline and the dopamine are 2 more medicines that can be given to the patient of bradycardia. But these 2 medicines are not important to know for your exam. So if you want to leave, you can leave, but do not leave the dose of atropine. So atropine is important drug for bradycardia. The dosage of atropine is important. The other drugs like dopamine, adrenaline are not important. Now let's talk about the tachycardia. Now who will tell me the drug of choice for tachycardia? So life-threatening tachycardia in ACLS protocol. What is the best medicine to be given? Milligram per kg. No, Dr. Nimish Chen, in cardiovascular system and in autonomic system, maximum you have to remember 4 dosage only. You have to remember the dose of only 4 to 5 drugs. And in this protocols, we'll discuss all these 5 drugs. We'll discuss all these 5 drugs. So only these 5 doses you have to remember. Right? Okay, so answer is for the treatment of life-threatening tachycardia, supraventricular tachycardias. For life ACLS protocol, mein beta blockers have no role. We prefer to give adenosine. So adenosine is a medicine that is given for the life-threatening tachycardias. So life-threatening tachycardias, adenosine is a medicine that has a role. So these are the life-saving drugs we are discussing right now, ACLS protocols, advanced cardiac life support protocols. So they are the cardiac life support. Life support है, तो patient is almost at the verge of death, or patient is so much of symptomatic that patient life is affected. So we can give this medicine to a patient. So adenosine is given, and for adenosine, I would say the first dose. Who will tell me the first dose of adenosine and the second dose of adenosine? What is the first dose and the second dose of adenosine? Anyone would like to answer? What is the first and the second dose of adenosine for the treatment of tachycardia? For the treatment of tachycardia, what is the first and the second dose of adenosine? Anyone? Very good. So the first dose of adenosine is 6 milligram and the second dose of adenosine is 12 milligram. So 6 milligram and 12 milligram, the first and the second dose of adenosine that is given for the treatment of tachycardia. Intisha, adenosine dosage is the only one where we start with the low dose, then we double the dose. Rest of the places we do other way around. That's why it's a bit confusing. Adenosine dose is the only one where we start with the low dose and later on we double the dose. Second dose is doubled, the first dose is half. But for all other conditions, we give the double dose first, then we half the dose. So please, Intisha, don't get confused in this. Adenosine first dose is 6 milligram, second dose is 12 milligram, and this dose is always followed by the saline push. So this is always followed by the saline push because we know that adenosine half-life is very short. Adenosine half-life is very short. It is metabolized in the RBC at a very fast rate. So if I give this medicine without the saline push, medicine is not able to reach up till the heart. Medicine is not able to reach up till the heart. Medicine gets metabolized before it will reach up till the heart. So we give the first dose 6 milligram followed by a saline push, or the patient is not revived. We can give 12 milligram dose as a second dose because we know that the metabolism of the drug is very fast. Now let's talk about the cardiac arrest. Now whenever the patient has come to you with cardiac arrest, now there are two types of presentation. In cardiac arrest, we have the two types of presentation. The first presentation is, no doctor, this is a stat dose. Arushi Saxena, the doses are stat dose. They are not in milligram per kg. They are the stat dose. These are the stat dose of the medicines that we are discussing. Stat means in one go you have to give the full dose. Now if we talk about the cardiac arrest, so patient can have two types of presentation. Patient can have two types of presentation. The patient might come to you with non-shockable rhythm. So patient might come to you with non-shockable rhythm, or patient can come to you with shockable rhythms. So patient can come to you with shockable rhythm, or patient can come to you with non-shockable rhythm. Now the patient has come to you with non-shockable rhythm. So here there is no role of giving a DC shock. So for the non-shockable rhythm, the presentation can be pulseless electrical activity. The presentation can be pulseless electrical activity where the patient ECG will be flat. So we call it PEA, pulseless electrical activity. So pulseless electrical activity, like there is no pulse, pulse is absent, but there is when you perform the ECG, not the flat ECG, sorry for that. So pulseless electrical activity means when you perform the ECG, you will have some waves in the ECG, but still you don't have the pulse. The second presentation is asystole. Now asystole is a condition where the patient will have the flat ECG. Here the patient will have the flat ECG, so we call it asystole. So asystole, patient will have almost flat ECG, patient will not have any pulse. So these two are known as non-shockable rhythm. So first is pulseless electrical activity, the second is known as asystole, non-shockable rhythm. So in these patients of pulseless electrical activity or the asystole, first of all you will start the CPR. You will perform the CPR 2 times, you must be knowing. So CPR is done 2 times, and how to perform the CPR, this will be covered in your anesthesia class. So anesthesia faculty will teach you the exact way to perform the CPR. But even after that, the patient is not revived. Like we do CPR for 2 minutes. So after 2 minutes, patient is not revived. We will do the CPR again for 2 minutes. Again, the patient is not revived. Now we have to give the medicine adrenaline. So adrenaline is the best medicine to be started over here. So adrenaline is a medicine that is given. Now if we talk about the shockable rhythms. In shockable rhythms, there are two types of presentation. One is known as ventricular fibrillation. First is known as ventricular fibrillation. Second is known as pulseless ventricular tachycardia. So first is ventricular fibrillation. Second is known as pulseless ventricular tachycardia. So ventricular fibrillation, pulseless ventricular tachycardia. So here, first of all, you will give the shock. Patient is not revived, you will perform the CPR. So like immediately after shock, you will start the CPR. Patient is not revived, you will again give the shock, then again the CPR. Then again after that, you will give the adrenaline. So adrenaline is given after 2 attempts of shock and 2 attempts of CPR, right? So give shock, then CPR, then shock, then CPR for 2 minutes, then give adrenaline. Now here they will ask you, what is the dose of adrenaline? So anyone would like to answer, what is the dose of adrenaline? So you have to answer me 3 questions. Number 1, what is the dose of adrenaline? What is the concentration of adrenaline that we will use? And what is the route of administration of adrenaline? So 3 questions you have to answer me. What is the route of adrenaline? What is the dose of adrenaline? And what is the concentration of adrenaline that we use? No, Rishabh, it's not 0.5 milligram. 0.5 milligram to anaphylactic shock ka dose hai. In this case, the patient is more sick. Here the patient is more sick. So 0.5 milligram is the dose for anaphylactic shock. This is not anaphylactic shock. This is cardiac arrest. So cardiac arrest mein we have to double the dose. The patient is more sick now. This patient is more sick and that's why you have to double the dose. So the dose is not 0.5 milligram. No, doctors, you all are answering incorrectly. No intramuscular. Guys, how intramuscular? This is cardiac arrest. You people are getting confused with anaphylaxis. This patient is already dead. When the patient is already dead, patient is already gone, what's the point of giving the medicine by intramuscular route? In this patient, you people even cannot find the veins. In this patient, you people cannot find the veins even. If you cannot find the veins, how can you expect that medicine can be absorbed by the intramuscular route? So medicine cannot be absorbed by the intramuscular route. If you inject the medicine by intramuscular route, medicine remain there. Medicine cannot be taken up by the plasma because there is no plasma flow. There is no blood flow in the patient body. So how will you revive the patient? Yes, the answer is IV route. Here the best route is IV route. Here the best route is IV route. So don't get confused with anaphylactic shock. Anaphylactic shock patient is bit stable patient. So here the route is intravenous route. And if you cannot find the veins, then you can give medicine by intraosseous route. So first is the intravenous route, second is the intraosseous route. So intravenous route is the first route. If not possible, you cannot find the superficial veins. When the veins are collapsed, you can give medicine by intraosseous route also. So first answer is intravenous followed by the intraosseous. Now the dose of the medicine is 1 milligram. So dose of the medicine that you have to give is 1 milligram. And which concentration that you will use? So this is a bit controversial. Which concentration that we need to use? So we have a bottle of adrenaline with a concentration 1:1000. So we have a bottle of adrenaline with a concentration 1:1000. And in this bottle of adrenaline, like if I draw the bottle of adrenaline, so this is the bottle of adrenaline. So this contains 1:1000 dilution of adrenaline, right? And it contains 1 milligram of drug per ml. So this bottle, which is approximately of 25 ml bottle, so this contains 1 milligram drug per ml. So here you have to give the dose 1 milligram. And because you have to give the dose 1 milligram, from this bottle you will take out 1 ml of the liquid. You will take out 1 ml of the liquid. So this 1 ml is equal to 1 milligram now. Now when you inject this medicine by 1 ml, 1 ml of this medicine is injected. This is followed by the 10 ml of the normal saline push. You will give the 10 ml of the normal saline push. So 1 ml bottle, 1 ml drug you will take out and you will give 10 ml of the normal saline push. And when you add on this 10 ml of normal saline, this will become 1:10,000 in your body. So this will become 10 times more diluted. And when it will become 10 times more diluted, so this is 1:10,000, that is ultimately acting in the patient body. So out of this 1:1000 bottle, you have made this liquid 1:10,000 in the patient body by giving this 10 ml of normal saline push, because you know that the medicine is not being able to reach up till the heart. Or the second option, in the same syringe, you can just add on the 10 ml more water, 10 ml more normal saline. So you can make it 1:10,000 outside the body also. So basically you have to inject, this is the concentration that is acting in the patient body, but you don't have any 1:10,000 per patient available these days. So you have only one bottle available these days, that is 1:1000. Yes, this is what I told you. You can take the one syringe. You can take the one syringe 1 ml plus 9 ml you can add over here. So 1 ml of adrenaline, 9 ml of normal saline you can add in this syringe. So this you can make 1:10,000 also. Basically, you have to increase the quantity of the drug. Why you want to increase the quantity of the drug? Because your patient is already collapsed. When the patient is already collapsed, the medicine is not able to reach up till the heart. So you have to give the at least 10 ml of the liquid. That will take care of your patient condition. Right? So this is how we give the medicine. Now this year in your exams, I would like to show you one thing to you. Guys, give me 1 minute. So these are your NEET PG question, which is asked this year in 2023. Now, can you please recognize which route of drug administration is this? Can you please recognize which route of drug administration is this? This is which route of drug administration? This was the question asked in your NEET PG 2023. This is the intraosseous. So please remember, for the intraosseous route, we use which bone? Answer is shin bone or the tibia. So tibia is the most superficial bone that we can use for intraosseous route. Right? So intraosseous route, we can give the medicines, we can give the fluids also. So fluid therapy can be given to revive the patient. So this is the intraosseous route. Good. So guys, here you have to answer me two questions. There are two conditions. One is known as anaphylactic shock. Second is known as cardiac arrest. So one is known as anaphylactic shock. Second is known as cardiac arrest. So if I talk about anaphylactic shock and cardiac arrest, we know that the drug of choice is adrenaline. So adrenaline or the epinephrine is the best medicine for anaphylactic shock, and it is also the best medicine for cardiac arrest. So both conditions, adrenaline is a drug of choice. Now what is the dose of this medicine for shock and cardiac arrest? Right? What is the route of this medicine for cardiac arrest and shock? And what is the concentration that we will use? So anyone would like to answer this question? Anyone would like to answer this question? Adrenaline, anaphylactic shock, what is the dose? What is the route? What is the concentration? Because I have found from you people that you people are a bit confused in this dosage and all. That's why I just want to clarify all these things. Yes, Arushi, this is a bit controversial question. Which concentration we have to give to cardiac arrest patient? Actually, the concentration that is acting in the patient body is 1:10,000. But the preparation that we have available in the market is 1:1000. So the bottle which is available in the market is 1:1000. But the concentration that is acting in the patient body is 1:10,000. That's why there's a controversy. Like what exact question they can ask. Till that, they haven't asked this question. Because even the examiner know this is a bit confusing. Arushi, let me clarify one more thing. Previously, up till 2018 and 19, we used to have two preparations of adrenaline. One was 1:1000, one was 1:10,000. Right? Here we used to have 1 milligram per ml. Here we used to have 0.1 milligram per ml. So this is 10 times more diluted. So 1:10,000 was 10 times more diluted. But nowadays, this preparation is not available in the market. So we have only one preparation left, that is 1:1000. This is available in the market. So 1 milligram per ml is available in the market. So we have to use only this bottle for all cases. But what concentration patient is receiving, that is different. That can be different. That you can dilute as per your need. Right? So this is the answer of your question. Okay, so what we have discussed so far, anaphylactic shock, the dose is 0.5 milligram. The dose is 0.5 milligram that we have to give. So the concentration is 1:1000. So I have to just take out 0.5 ml of the liquid. I have to just take out 0.5 ml of the liquid because in this concentration, the drug amount is 1 milligram per ml. The route of administration is intramuscular route. The best route is intramuscular route, and the muscle that we use most commonly is vastus lateralis. So the muscle that we use most commonly is vastus lateralis, that is a thigh muscle. So in thigh muscle, we will give 0.5 milligram of the drug. Now, if we talk about cardiac arrest, the dose is just doubled. So the dose is just doubled, it's a 1 milligram dose. So dose is just doubled, it's a 1 milligram dose. The route is intravenous. The route is intravenous, not possible, give the medicine by the intraosseous route. Right? Now, which concentration that you will take out? You will use 1:1000 bottle, no doubt about that. 1 ml drug you will take out, but you will make it 1:10,000, and then you will, this is the concentration that will act in the patient body. So this is the concentration that will act in the patient body, and you have given it by the intravenous route. Right? Okay, now there is one difficult question for you people. So are you ready for the difficult questions, or are you comfortable with this much only? So can I ask one difficult question from you people? Can I ask one difficult question from you people, if you are comfortable so far? No? Okay, no problem. So let's move on to the third question now. No, okay, one thing is left over here. Let me check the students who are there on the YouTube. So on YouTube, yes, so on YouTube we have multiple students there. Dr. Nilay Kumar, Dr. Akhil Thoda, Dr. Ashish Kumar, Netra Prasanna, all of you are there. So I'm happy to see that you people are participating in this test and discussion. So let me okay, so let me ask you one more question from you people, because now it has given me a moral booster that so many students are there online on YouTube also. So my question is, for the treatment of anaphylactic shock, if I want to use adrenaline by the IV route, if I want to use adrenaline by the IV route for the treatment of anaphylactic shock, then what should be the dose? What should be the concentration? Route though we have discussed already, it's a IV route. So if I want to use adrenaline for the treatment of anaphylactic shock by the IV route, then what is the route? What is the concentration that we should use? Akhil Thota, Dr. Rakshanda, Dr. Nilay Kumar, Netra Prasanna, Dr. Next PG Trivia, where are you? You have stopped answering. Very good. Now, whenever I have to give medicine by IV route, I have to decrease the dose first. Because now I am giving the medicine by the IV route. If I give 0.5 milligram drug, if I give 0.5 milligram drug, this is going to definitely cause the arrhythmias. So this dose 0.5 milligram is a very high dose. So first of all, I will reduce the dose to 0.1 milligram. First of all, I will reduce the dose to 0.1 milligram. When I reduce my dose to 0.1 milligram, and if I open the bottle of 1:1000, if I open the bottle of 1:1000, which contains 1 milligram drug per ml, which contains 1 milligram drug per ml. So I have to just take out 0.1 ml of the liquid. Now practically it's not possible to take out the 0.1 ml of the liquid, because in syringe, if I take out the 0.1 ml of the liquid, I cannot see that any volume is there, because even the syringe needle has some volume. Syringe needle has some volume, so 0.1 ml will remain in the needle only. I cannot see anything in my syringe. So practically it's not possible to take out 0.1 ml liquid from this bottle. So what exactly we do? We will have a pre-filled syringes. We will have a pre-filled syringes available in the market of 1:10,000. So if I'll use 1:10,000 pre-filled syringes, this contains 1 ml of the liquid. So 1 ml of this liquid is equal to 0.1 milligram. Do you remember the two bottles which we discussed? So the second bottle was 1:10,000. It contains 0.1 milligram drug per ml. So if I want to give 1.1 milligram of the drug, so I can just take out 1 ml of this drug and I can give it to the patient. So 0.1 milligram drug I can give. The dose is very low. Dr. Zainab has given the correct answer. It's 0.1 milligram. Intisha has given the correct answer. Right? Even the Urja has given the correct answer. But quantity mein thoda dhyan rakhna. So we have to give 1:10,000. That is equal to 1 ml. That is equal to 1 ml. याद रखना इस पॉइंट को. In previous case, if you look at the ml, it's only 0.5 ml. Here the ml is 1 ml. Right? In previous case, it was 0.5 ml. Here it is 1 ml. But in the previous case, the drug was more concentrated, 1:1000. Here the drug is more diluted. There the dose was 0.5 milligram. Here the dose is very less, 0.1 milligram. Understood? This is how we give medicines to our patients. This is all about the adrenaline dosage. Now come back to this ACLS protocols. So if you go back to this ACLS protocols, now in patients who have shockable rhythms, after giving noradrenaline, if the patient is not revived, so after adrenaline, patient is not revived. So the patient is not revived even after giving adrenaline, then which two medicines I can give? So I can give amiodarone, I can also give lignocaine. So I can also give amiodarone and lignocaine. So lignocaine and amiodarone are two more medicines which I can give to a patient of shockable rhythm. Now, who will tell me the dosage of this medicine? So let me tell you without wasting much of your time. The first dose of amiodarone is 300 milligram. The second dose is 150 milligram, bolus dose, stat dose. And lignocaine dosage is 100 milligram. The second dose is 50 milligram. Now, lignocaine dosage is defined in terms of milligram per kg also. So it is 0.75. It's 1.5 milligram per kg. It's 1.5 milligram per kg, which is almost equal to 100. And second dose is 0.75 milligram per kg. So this is the dosage of lignocaine and amiodarone given to a patient of ventricular fibrillation or pulseless ventricular tachycardia. So basically here we have remembered 5 dosage, and these 5 dosage are very important for your exam. The first dose is of adenosine. So adenosine dose is 6 milligram followed by the 12 milligram. In cardiac arrest, we have remembered 3 dosage. First dose is of adrenaline. The second is amiodarone and lignocaine. Right? Second is adrenaline. Third is amiodarone. Fourth is lignocaine. And the fifth one is of atropine, that is given for bradycardia. So this is all about this ACLS algorithm that you people can expect to be asked in your INA-CT exam. In your NEET exam, they mostly ask you these things superficially. Now let's move on to the question number 3. So after that, we can move on to question number 3. A 42-year-old woman present to her doctor office complaining with worsening of fatigue. Right? So she is having the worsening of fatigue. Now she has noticed that she has difficulty in opening her left eye. And also she states that she feels fine when she wakes up. So in morning she is not having the symptom, but the symptoms become worse during the evening time. So towards the end of the day, the symptoms become worse. Now, which medication is used for the treatment of this condition? First of all, you people have to make the diagnosis. Now, after making the diagnosis, you have to give me the best medicine that is given for the treatment of this condition. So anyone would like to answer? No one is there? Okay. Yes, the answer is, it's a case of myasthenia gravis. Very good. So Dr. Rishabh, Amrita, Achal, Intisha, Jigar, Zeel, Swayam, Komal, Aruni, Arushi, all of you have given the correct answer. It's a case of myasthenia gravis. And for the case of myasthenia gravis, the drug of choice is pyridostigmine. So drug of choice is pyridostigmine that you people have to mark. Right? So now let's discuss this question, myasthenia gravis. So if we talk about question number 3, so we are on question number 3. So the answer is pyridostigmine. Answer is D. Right? So question number 3, the answer is D. The case of myasthenia gravis. So whenever the patient of myasthenia gravis will come to you, what is the basic problem in myasthenia gravis? In myasthenia gravis, the patient will have the formation of antibodies. Patient will have the formation of antibodies against the NM receptor. Right? So this is the somatic nerve. So this is the somatic nerve. This somatic nerve can release acetylcholine. So somatic nerve can release acetylcholine. Acetylcholine can act on nicotine M receptor, and by acting on nicotine M receptor, this can cause muscle contraction. So muscle will be contracted when this acetylcholine will act on NM receptor released by the somatic nerve. Now we know that acetylcholine after doing this action is metabolized. So acetylcholine is metabolized by an enzyme known as acetylcholine esterase enzyme. So acetylcholine is metabolized by acetylcholine esterase enzyme after doing this action. Now the patients who have the overactive thymus, so most of these patients have the history of thymoma. So they have the thymoma. So thymoma has produced antibodies, and these antibodies are trying to bind with this NM receptor. Now when the antibodies will bind to this NM receptor, the NM receptor will be destroyed. The NM receptor will be destroyed. This is known as myasthenia gravis. So what you have to do, you have to keep this acetylcholine level higher than the antibody level. So if you keep this acetylcholine level higher than the antibody level, then this antibodies will not win this competitive race. So antibodies will be left behind. Acetylcholine will go and bind to the receptor on daily basis, and by this way you can save your receptor. By this way you can save the strength of your muscle, and this is how we treat a patient of myasthenia gravis. So which medicine I can give? I can give a drug which is inhibitor of acetylcholine esterase enzyme. So acetylcholine esterase enzyme inhibitor, the drug name is pyridostigmine followed by the neostigmine. So pyridostigmine, neostigmine are two medicines that I can use to inhibit this acetylcholine esterase enzyme. Now what is the difference between two? If I talk about the difference between pyridostigmine and neostigmine, so we know that pyridostigmine is a long-acting drug, and because of it's a long-acting drug, this is given less number of times. But neostigmine is comparatively having the short action, so this medicine has to be taken more number of times by the patient. Now pyridostigmine has a slow onset of action. So this medicine has slow onset of action, having the long action but slow onset of action. But neostigmine has having the short action but having the fast action. Fast onset. So neostigmine has fast onset but having the short action. There's a difference between two. That's why pyridostigmine is preferred over neostigmine. Right? Now whenever the patient of myasthenia gravis will come to you, now the patient of myasthenia gravis will come to you with three types of presentation. So patient can come to you with local muscle weakness. So patient can come to you with local muscle weakness. So most of the time the eye muscles. Most of the time the eye muscles are involved. So patient will come to you with paralysis of eye muscles or the weakness of eye muscles, or patient might come to you with generalized muscle weakness. So patient can come to you with generalized muscle weakness, local muscle weakness, or the patient can come to you in myasthenia crisis. Now in patients of local muscle weakness, you start your treatment with pyridostigmine or you can give neostigmine, but along with pyridostigmine and neostigmine, you have to give low dose of atropine. You have to give low dose of atropine as a best treatment for myasthenia gravis. Now anyone would like to answer why we give low dose atropine? Why we give low dose atropine along with pyridostigmine and neostigmine for treatment of myasthenia gravis? Anyone would like to answer? Why in patients of myasthenia gravis we will give low dose of atropine? Why we will give low dose of atropine along with pyridostigmine and neostigmine? No one can answer this question. Let me check the YouTube students. YouTube students, Dr. Kapil, Dr. Hector, Dr. Netra. Very good. So Dr. Nile has given the correct answer. Very good. So all of you have given the correct answer now, because atropine is given to prevent the autonomic side effects. So to prevent the muscarinic side effect of pyridostigmine and neostigmine, we will add atropine. Now after starting this treatment, patient symptoms are not controlled. So patient symptoms are not controlled after adding this treatment. What is the next step to do? Anyone would like to answer? Which other medicines we can add in the patient treatment? So I have given pyridostigmine and neostigmine, but even then the patient symptoms are not relieved. If you look at my hand, patient has more antibody level, less acetylcholine level. So after giving pyridostigmine, you have increased the acetylcholine level. But now the acetylcholine which you people have increased is not sufficient enough to bypass or to overcome this antibody level. antibody count is very high. If you look at my left hand, antibody level is very high. The right hand is acetylcholine. I have increased acetylcholine level, but still it is not sufficient enough to uh, overcome this antibody level. What is the next step to do? No, Dr. Achal. Rishabh has given the correct answer. Achal, Harisimran, Zainab, try to understand. Plasmapheresis and immunoglobulin are the emergency treatment. Plasmapheresis, immunoglobulins are the emergency treatment. So this is not the emergency. Patient has just come to you with eye muscle weakness. Patient has come to an OPD. She is a female and she is saying, "Ki, sir, in morning time I am fine. In evening time I cannot open my eyelid. So is this an emergency?" Answer is no. This is not an emergency. So why we should go for plasmapheresis? Why we should go for IVIGs, right? So here we have to give a medicine by the oral route. So it's better to add immunosuppressants. So immunosuppressants is the best answer to be added over here. Now guys, we know that the most commonly used immunosuppressant is steroid, but here in this case we avoid the steroids because the patient is a case of myasthenia gravis and steroids have a long-term negative effect on the muscles. So we can add any immunosuppressant, there is no harm in that. Even I can add steroid also. But if I add the steroids, steroids have the negative effect on the muscles. One of the long-term side effects of the steroid therapy is muscle atrophy. So I will not add the steroids. The best immunosuppressants that can be added in the patient treatment is azathioprine. So I can add azathioprine. I can also add mycophenolate mofetil. So these are the two steroids which have the best results. These are the two immunosuppressants which have the best results. Azathioprine and mycophenolate, these are the two immunosuppressants which have the best results, having the minimum side effect in the patient body, especially the case of myasthenia gravis. So this is how we manage the case of local muscle weakness. Now, when the patient is having generalized muscle weakness, here the main problem is respiratory muscles get involved. So generalized means when all muscles are getting weak, including the respiratory muscles. So here in this case, you have to give the drug therapy, no doubt about that. So you have to give the drug therapy. You will start pyridostigmine and the neostigmine. Plus, you can also take the patient for the removal of the thymus, that is thymectomy. So along with the drug therapy, you have to go for surgical therapy also. So here in this case, along with the drug therapy, you have to go for the surgical therapy also. Now, after removing the thymus gland, if the patient's symptoms are not controlled. So even after removing the thymus gland, patient symptoms are not controlled. It means not only the thymus, even the other lymph nodes can also be involved. Or maybe the thymus was not involved at all. So after removing the thymus, if the patient's symptoms are not taken care of, it means the other lymph nodes are also involved. And now you have to suppress those lymph nodes by giving the immunosuppressants. So here also you will add the immunosuppressants if the patient's symptoms are not controlled. When the patient has myasthenia crisis, now myasthenia crisis is something where immediately there is excessive antibody production. And because of this antibody excessive production, even if you give pyridostigmine over here, this pyridostigmine cannot control this antibody count. And also if you start the immunosuppressants, they are the slow acting medicines, they will take time to act. So here in this case of crisis, you have to remove the antibodies. Here in this case of crisis, you have to remove the antibodies on urgent basis. Therefore, there is a role of plasmapheresis. So here you have to remove the antibodies on urgent basis. Or you can give intravenous immunoglobulins that will suppress the antibody count. Or you can also give IV steroids because steroids are the immunosuppressants which are the fastest acting immunosuppressants. Although we have a limitation in myasthenia gravis to use steroids for the long term, but I can use short course of methylprednisolone at least for 14 days to take care of this patient. So to stabilize this patient, I can go for plasmapheresis. If not available, I can go for intravenous immunoglobulin, and side by side I can start a short course of methylprednisolone for this patient. This is how we manage a case of myasthenia gravis. Right? Now after this myasthenia gravis, you should be knowing for your INSCT exam the drugs that is avoided. So the drugs that is avoided in patients of myasthenia gravis. So there's a table given in your Harrison. So please read that table, the medicines that are avoided in patients of myasthenia gravis. This is important for your INSCT exam. So drugs that are avoided in myasthenia gravis, if you want, I will share that table with you in your group. Otherwise, you can go and open the Harrison. It's given there beautifully. Even this flowchart I have taken from Harrison. So you can open your textbook. This table is given in, this flowchart is given in Harrison. So this is all about the myasthenia gravis. Now, guys, there is one question from you people. If the patient is having cobra bite, right? So which medicine is better? Pyridostigmine is better or neostigmine is better? Can you please answer? So patient who has come to you with cobra bite, the cobra will secrete a venom in the patient body. This venom will also block the NM receptor and the patient will have the muscle weakness. So patient bitten by cobra, patient can come to you with muscle weakness. Now what is the best management of cobra bite? Guys, why neostigmine? Why not pyridostigmine? So along with the anti-snake venom, we will give neostigmine. So here we will give neostigmine along with atropine. Now guys, why we give neostigmine? Why not pyridostigmine? Can you answer this question? Why neostigmine? Why not pyridostigmine? Why neostigmine? Why not pyridostigmine? So why neostigmine is a better answer? Very good. So Dr. Nile has given the answer because neostigmine has a faster onset of action. Neostigmine has a faster onset of action and this is a medical emergency. So that's why we prefer to use neostigmine over pyridostigmine. Right? So this is how we manage a case. Now one more question. Whenever you want a reversal of skeletal muscle relaxants, whenever you want a reversal of skeletal muscle relaxants, now skeletal muscle relaxants are the curium drugs. So any medicine that ends with the word curium or curare, even these medicines are blocker of NM receptor. So during surgery, you block this NM receptor by the curium drugs and now you want a reversal. Now which medicine is again used? So pyridostigmine is used or neostigmine is used? Pyridostigmine is used or neostigmine is used? Anyone would like to answer? Pyridostigmine or neostigmine for the reversal of skeletal muscle relaxants. So after surgery, once you have completed the surgery, now you want that patient should able to move his or her limbs. Which medicine is better for the reversal? Pyridostigmine or neostigmine? Very good. So answer is neostigmine is used. So the answer is neostigmine is used because again you required a fast action. Because you want a fast recovery of the patient. That's why neostigmine is used for the reversal of skeletal muscle relaxant. Now along with the neostigmine, you need not to give atropine over here or you can give some anticholinergic. Now you have two options. You can give glycopyrrolate, or you can give atropine. Now who will answer me which is better? Because guys, these kind of clinical questions they can ask you. Along with the neostigmine, you have to give an anticholinergic. Glycopyrrolate or atropine are two options which are the anticholinergic drugs that can be given to prevent the autonomic side effects, to prevent the muscarinic side effect. Which one is preferred and why? So out of atropine and glycopyrrolate, which one is preferred and why? Yes, answer is correct. Dr. Somit, Dr. Rishabh, Intisha, Zainab, Amrita, Zeel, Azvikam, Nimisha Jain, all of you have given the correct answer. So we prefer to use glycopyrrolate. We do not use atropine because glycopyrrolate is a drug which cannot cross blood-brain barrier. This medicine cannot cross blood-brain barrier, so patient will not have the post-operative CNS side effect. So this medicine has quaternary structure. Because of the quaternary structure, this medicine will not produce CNS side effects. So atropine is not preferred because skeletal muscle relaxants are the peripherally acting drugs. They will produce their effect only in the periphery. We need not to give atropine for that because atropine is a drug that can cross blood-brain barrier. Okay, the last question for you people. You have to answer me the question. If the patient is having the datura poisoning, what is the antidote of choice? What is the antidote of choice for the patients who have the datura poisoning? Datura poisoning antidote, who will tell me? What is the name of the antidote of datura poisoning? Name of the antidote of datura poisoning? Yes, answer is physostigmine. Very good. So it's not pyridostigmine, it's physostigmine. So physostigmine is a name of the antidote. Now, do we give atropine along with physostigmine here? Do we give atropine along with physostigmine for the treatment of datura poisoning? One stupid question I have asked, but you have to answer me. Physostigmine is a best medicine for datura poisoning. Do we give atropine here? Answer is no. We will never give atropine because Datura poisoning is other name of which poisoning? Atropine poisoning. Datura poisoning is other name of atropine poisoning. So there's no point of giving atropine. I will only give physostigmine. So physostigmine I will give. I will not give atropine because Datura poisoning is other name of atropine poisoning, belladonna poisoning. Okay, one more poisoning I would like to ask in relation to autonomic system, that is organophosphate poisoning. Now organophosphate poisoning, who will answer me which treatment you will give to the patient? What is the name of the antidote? Organophosphate poisoning, what is the name of the antidote? The answer is, the name of the antidote is atropine. So organophosphate poisoning, the name of the antidote is atropine. But along with the atropine, which other drug is given? Along with the atropine, which other drug is given for OP poisoning? For OP poisoning, along with the atropine, which other drug is given always? Anyone would like to answer? In OP poisoning, along with the atropine, which other drug is given? Only atropine? Very good. So you people have answered correctly. We will give a drug known as pralidoxime or oxime. So along with the oxime, along with the atropine, we always give the oxime for the treatment of OP poisoning. Okay. Now, whenever we give atropine for the treatment of OP poisoning, we initially give the bolus dose. Initially, we give the bolus dose of atropine. Initially, we give the high dose of atropine, bolus dose of atropine to stabilize the patient. So whenever we have to stabilize the patient, we have to give the initial high dose. We have to give the initial bolus dose or initial high dose, right? And when we give this initial high dose or the bolus dose, this is known as atropinization. This is known as atropinization. Then how will you come to know? How will you come to know that patient has received sufficient atropine? Now you cannot continue with the high dose of atropine, otherwise patient will land up in atropine toxicity. So treatment of OP poisoning, when you start atropine, you have to monitor few points. We call them the therapeutic endpoints. That you need to monitor. So during OP poisoning, when you give atropine in high dose, then you have to monitor some therapeutic points. Now, which are the most important therapeutic endpoints? So most important therapeutic endpoints are, number one, there's a dryness of secretion. So dryness of secretion is the best therapeutic endpoint that you will observe. So dryness of secretion is the best therapeutic endpoint that you will observe. Dr. Micro, dry tongue नहीं देखते बच्चे इसमें हम, tongue is not monitored for dryness. Mostly we will use the vacuum to take out the tracheobronchial secretions, or if you don't have the vacuum, you will check the patient axilla देखते हैं. So salivation we will not check. We will check the tracheobronchial secretion with the help of vacuum, or we will check the axilla if we don't have the vacuum. So the most specific, most important parameter is dryness of secretion. The second is the patient chest should be bilaterally clear. So patient chest should be bilaterally clear. It's the second best therapeutic endpoint that you will observe. So patient chest should be bilaterally clear. Bronchial secretions should not be there. There should not be a noise of wheezing. There should not be a noise of secretions in the bronchiole. So bilaterally chest is clear. It's the second best therapeutic endpoint that you will observe. Right? Yes. So you will not hear that wheeze. You will not hear that secretion sound. So these two are the best therapeutic endpoint that you will observe when you give atropine to a patient in high dose. Now after this things are achieved, then you will put patient on low dose of atropine. You will put patient on low dose of atropine and you will continue, you will discharge the patient. Now I would like to ask you one question. Assume you have achieved this therapeutic endpoint. You have achieved this therapeutic endpoint, even then you are not reducing the dose of atropine. Even then you are not reducing the dose of atropine, you are still continuing with the high dose of atropine. Now patient can land up in atropine toxicity. So patient can land up in atropine toxicity. And how will you come to know that it's atropine toxicity? Can you please tell me some symptoms of atropine poisoning, atropine toxicity? Can you please tell me some symptoms of atropine toxicity or atropine poisoning? Or other way, what you can do? You can just answer me this question. You can just answer me this question so that I will say that you people have understood this question. Now, what is the answer of this question? This is the NEET PG 2023 question. This is the NEET PG 2023 MCQ. Who will answer me this MCQ? A patient with OP poisoning. A patient with OP poisoning was given atropine and pralidoxime. Patient developed high-grade fever after 2 hours of treatment. So, in starting, you have given the high dose of atropine to stabilize the patient. So, within few hours, you will stabilize the patient. But patient has started getting the high dose of atropine. What is the best answer? It's the best answer is atropine side effect. This is the atropine side effect that has occurred. It's a patient has landed in atropine poisoning. So, patient has landed in atropine poisoning. This is the best answer you people are supposed to mark. Right? Okay, who will answer me this question? This is again a NEET PG 2023 question. So this is a NEET PG 2023 question. One more question from autonomic nervous system, NEET PG 2023. A child presented to hospital. A child presented to hospital with agitation, photophobia, retention of urine. History reveals that he has eaten a wild fruit. The child has eaten a wild fruit while playing with his friend. So while playing with his friend, he has eaten a wild fruit. Which of the following is likely cause with the best treatment available? So this is which poisoning? Answer is this is datura poisoning, and the antidote of choice is physostigmine. So can you imagine, like, can you compare the level? Can you compare this level of INSCT and NEET PG? So NEET PG, the question level is bit easy. In NEET PG, the question level is bit easy. So the answer is datura poisoning, and the answer is physostigmine. So antidote of choice is physostigmine. Okay, so antidote of choice is physostigmine. Now again, guys, I'm giving you one exercise to do. Can you please answer me these questions? I'm giving you one exercise. Can you please tell me the antidotes of all these medicines? You have to just send me a message containing 6 points. Antidotes of OP poisoning, antidotes of atropine poisoning, cobra snake bite, scorpion bite, theophylline toxicity, and beta blocker toxicity. Who will send me the antidotes of OP poisoning, atropine poisoning, cobra snake bite, scorpion bite? So scorpion bite is asked in INI-CT exam. So INI-CT 2023, they have asked you scorpion bite, right? Atropine, they have asked you NEET PG 2023, we have discussed. This is OP poisoning is also asked in NEET PG 2023. So can you imagine like how important this topic is? So autonomic system, so many poisonings, so many antidotes you need to remember. So OP poisoning, what is the best answer? Atropine poisoning, what is the best answer? Cobra snake bite, what is the best answer? Theophylline toxicity, which answer you will mark? And beta blocker toxicity. So all these are poisonings which can be asked in relation to autonomic nervous system. So Dr. Rishabh has tried to answer. Let me check the answer. Rishabh has said for OP poisoning, it's atropine. For atropine poisoning, it's other way around, physostigmine. Right? For the cobra snake bite, we will give neostigmine. For scorpion bite, we will give prazosin. For theophylline toxicity, we will give esmolol. And for beta blocker toxicity, we will give glucagon. So यहाँ पे कुछ mistakes हैं यार. There are some mistakes. Now Arushi has answered correctly. Arushi has said in organophosphate poisoning along with atropine, the oximes are always given. So this is correct. Atropine के साथ oximes are always given. Although the antidote is atropine, no doubt. So Rishabh has answered correctly. But along with atropine, we always give oxime. Similarly, in atropine poisoning, similarly in cobra snake bite, along with neostigmine, the most important is anti-snake venom. So anti-snake venom is the antidote. Anti-snake venom is the antidote. Antidote यहाँ पे anti-snake venom है. Guys, please remember this point. Anti-snake venom antidote है. Neostigmine is only required for the faster recovery. It is only required for faster recovery, but it is given with atropine low dose. So anti-snake venom is the antidote. Same thing applies to scorpion bite. In scorpion bite, the anti-venom. Anti-venom is the best answer. Anti-venom is the antidote, but prazosin is given to take care of the hypertension. Prazosin is given to take care of the hypertension, but the best treatment is again anti-venom. Right? Theophylline toxicity, ismolol correct hai. Beta blocker toxicity, glucagon correct hai. Right? Now I will display one MCQ and you have to answer me that question. So these are the NEET INSCT May 2023 questions. Can you please answer me this question? A child has gone with her grandmother, Nani means the grandmother, through temple, complaining burning sensation in his peripheries, having the tachycardia, having the high blood pressure and priapism. So the baby has developed, that kid has developed, not the baby, the kid has developed tachycardia, fast heart rate, priapism and high BP. Right? What is the drug that need to be given? What is the best medicine to be given? Yes, तो यहाँ पे best answer है anti-venom. But according to some students in this year exam, anti-venom was not there in the MCQ. So when the anti-venom was not there in the MCQ, prazosin would be the best answer. So here the drug of choice would be anti-venom. But anti-venom, if it is not given, then prazosin will be the answer. So please check what was the exact question, because this is just a recent feedback which I have got from the students. Right? If anti-venom is not given, prazosin is the answer. If anti-venom is given, the best answer is anti-venom. ठीक है? So accordingly, you have to mark the answer. Okay, so guys, we people have covered up till here. So let me go back to the question number 3. So question number 3 we have covered. Question number 5 we people have also covered. So what is the answer of question number 5? Yes, so if anti-venom was there, so anti-venom is the best answer. Scorpion bite में आपको anti-venom देना होगा. Right? या गाइस एंटीवेनम तो देना ही पड़ेगा ना. हाउ हाइपरटेंशन क्राइसिस भी होगा तब भी. If there is no antivenom in the MCQ, I mean, how then prazosin will be the answer. Yes, question number 5 answer we have already covered. So 2 therapeutic endpoint. The best therapeutic endpoint is dryness of secretion. The second is bilaterally the chest is clear. Bilaterally the chest is clear. So 5 we have already covered. Now let's move on to question number 4. Now question number 4 is again from your NEET PG exam. Question number 4 is again from your NEET PG exam. What is the answer? Question number 4. A patient on nicotine and the clonidine treatment presented to you with headache after stopping clonidine 3 days back. Yes, the answer is rebound hypertension crisis. So patient has got rebound hypertension crisis. We also call it clonidine withdrawal syndrome. We also call it clonidine withdrawal syndrome. So clonidine withdrawal syndrome. So clonidine is a drug which will act on alpha-2 receptor. So clonidine is a medicine that will act on alpha-2 receptor. So we are going to discuss question number 4. So question number 4 answer is A. So clonidine is a medicine that will act on alpha-2 receptor. And alpha-2 is a type of inhibitory receptor that we have already covered. So this medicine will act in central nervous system and inhibit the vasomotor center. So this medicine will inhibit the vasomotor center, and by inhibiting the vasomotor center, this medicine can control the blood pressure. Now this clonidine can also act in periphery. So this can act in CNS, this medicine can also act in periphery. So when this clonidine will act in periphery, So this is the peripheral nerve. This is the peripheral nerve which releases noradrenaline. This is the peripheral nerve that releases noradrenaline, and now this noradrenaline will act on alpha 1 receptor, and by acting on alpha 1 or alpha 2 receptor, this medicine can cause this noradrenaline can cause high blood pressure. So norepinephrine can act on alpha 1, alpha 2 receptor, can result in high blood pressure. This we already know. Now presynaptically also we have the presence of alpha 2 receptor. So whenever I give clonidine, clonidine is a medicine. Clonidine is a medicine that will act on this alpha 2 receptor, and by acting on this alpha 2 receptor, this can inhibit the release of noradrenaline. So clonidine can inhibit the release of noradrenaline, and therefore the BP will start getting controlled because of this mechanism also. So main mechanism is this medicine will act on central nervous system. This is the main mechanism. So main mechanism is this medicine will act on central nervous system, and by acting on the central nervous system, this medicine will give negative stimulus to this peripheral nerve. And when this medicine will give negative stimulus to this peripheral nerve, first of all, norepinephrine will not form, and when the norepinephrine will not form, its further release is also blocked by the clonidine. Now, when the patient will stop clonidine immediately, what will happen? The CNS will start firing again. The vasomotor center is now open. When the vasomotor center is now open, this will again give a positive stimulus to the sympathetic nerve. Now, the sympathetic nerve, where the norepinephrine is not getting released, will start getting released with a very high rate. And this will cause rebound hypertension crisis. This is known as clonidine withdrawal syndrome. Right? So, clonidine withdrawal syndrome pe question hai. So, in this case, we can discuss one thing with you. Treatment of hypertension crisis I can discuss. So, if you want, we can discuss the treatment of hypertension crisis with you people. So, let me find out one exercise for you people. Guys, give me 1 minute only. Let me find out if... okay, so it's not there. So let me write these exercise for you. Whenever the question will come to you on hypertension crisis, question will come to you in hypertensive crisis, which is also known as hypertensive emergency. So hypertension crisis, hypertensive emergency, you will always mark nicardipine. So nicardipine along with labetalol. This is given for hypertension crisis. So hypertension crisis. Okay, you want to discuss again. Guys, whenever we stop clonidine, what will happen? Clonidine is the one that is acting on the CNS, so the vasomotor center become overactive. Vasomotor center, which was kept in inhibitory state by the clonidine, when it stop clonidine, this vasomotor center become overactive. When the vasomotor center become overactive, this will start stimulating the peripheral nerves also. This will start stimulating the peripheral nerves, like the sympathetic nerves are stimulated. Now, when this sympathetic nerve is stimulated, this will start releasing more norepinephrine. So you have given the clonidine. Clonidine is a drug that will act on your CNS, inhibit the vasomotor center. Clonidine will act in periphery, keep your norepinephrine release under control. So when I stop clonidine, the CNS is active. Even the peripheral nerve will start releasing more norepinephrine. And now they will act on the alpha 1 receptor. This will cause hypertensive crisis. Plus, this clonidine also stimulate the alpha 2 receptor periphery. Right? So, this clonidine is a medicine. This will, when you stop this clonidine, sorry for this, when you stop the clonidine, what will happen? The CNS is activated, and this will give positive stimulus to the sympathetic nerve. Sympathetic nerve, which is also under control of clonidine, will start releasing more norepinephrine, and through this alpha 1 and alpha 2 receptor, this will cause hypertension crisis. So this is rebound hypertension crisis. Postural hypotension. Guys, this is not postural hypotension, this is hypertension. Alpha 1, alpha 2 receptor से होगा hypertension crisis. Any doubt in this? No. Okay. Understood now. So hypertension crisis, we give nicardipine plus labetalol together. But there are 7 conditions. There are 7 conditions where this treatment regimen is not followed. There are 7 exceptions that you need to remember where this regimen is not followed. Total 7 exceptions are there. What are these 7 exceptions that we can discuss here? So these exceptions are: number 1, if the patient is having PIH, then nicardipine is not a preferred medicine. Patient is having pheochromocytoma, then the answer will be different. Patient is having clonidine withdrawal syndrome, the answer is different. Patient is having cheese reaction, the answer is different. Patient is having hypertension crisis due to the scorpion bite. Hypertension crisis with scorpion bite, the answer is different. Patient is having hypertension crisis due to some procedure, we call it intraoperative hypertension crisis. Intraoperative hypertension crisis. And the last is the patient is having hypertension crisis associated with aortic dissection. Hypertension crisis associated with aortic dissection. Here, nicardipine is not a drug of choice. Some other medicines will be the drug of choice. Now, who will solve this exercise for me? Nicardipine plus labetalol. Nicardipine plus labetalol is the best treatment for hypertension emergency or hypertension crisis. We give these drugs in combination because nicardipine can cause reflex tachycardia. To control that reflex tachycardia, we give beta blocker labetalol. But there are 7 conditions where this combination is not given. Anyone would like to answer? For PIH, pheochromocytoma crisis, cheese reaction, clonidine withdrawal syndrome, scorpion bite hypertensive crisis, intraoperative hypertension crisis, aortic dissection, which medicines are the drug of choice? So everywhere else you will mark nicardipine. So no problem, I will write it for you. So you people are not able to get this question. So labetalol. So here we will give only labetalol. Here we will not give nicardipine. Here only the labetalol is given. For pheochromocytoma, we prefer to use a medicine that is phenoxybenzamine. So phenoxybenzamine is the best medicine to be marked here. For clonidine withdrawal syndrome, for cheese reaction, we will give phentolamine. So phentolamine is given. For scorpion bite hypertensive crisis, we have discussed already. It's a prazosin. For intraoperative crisis, we will give sodium nitroprusside. So sodium nitroprusside you will mark as a best answer. And for aortic dissection, you will mark ismolol. You will mark ismolol plus nitroprusside. You will mark ismolol plus nitroprusside drug. So these are the exceptions that you need to be careful. For rest of the hypertension crisis, nicardipine is the most preferred medicine. Right? So this is all about the question number 4 for you people. This is the clonidine withdrawal syndrome. So when we stop clonidine, patient can develop rebound hypertension crisis. We can treat this clonidine withdrawal syndrome by giving a drug phentolamine. Right? So let's move on to the question number 6 now. So question 4 we have discussed. If you people have any doubt, please ask. Question 5 we have already discussed. What is the answer of question number 5? So question number 5, answer is C. Now moving on to question number 6. Which drug is not useful for the treatment of narcolepsy? So out of all these medicines, which drug is not given for narcolepsy? Anyone would like to answer? What is the answer of question number 6? Methylphenidate. No, बच्चे, methylphenidate is given for narcolepsy. Methylphenidate is given for narcolepsy. Yes, Dr. Rishabh has given the correct answer. Dexmedetomidine. Dexmedetomidine is a drug which is not given for narcolepsy. No, Tanisha, intraoperative hypertensive crisis, sodium nitroprusside is used. Sodium nitroprusside is the best medicine for intraoperative hypertensive crisis of any type. Dexmedetomidine is a sedative drug basically. This is a sedative medicine and this will act on alpha-2 receptor. So by acting on alpha-2 receptor, this medicine can inhibit the CNS activity. And by inhibiting the CNS activity, this medicine is given for ICU sedation. Medicine is useful for conscious sedation, ICU sedation. The drug name is dexmedetomidine. So this belongs to a class of alpha-2, dexmedetomidine. Rest of the medicines are stimulatory of CNS. They are given for narcolepsy. Now if I ask you guys this question, what is the drug of choice for narcolepsy? You have to find out the best medicine for narcolepsy. Can you find out the best medicine for narcolepsy in this MCQ? Which medicine is the best medicine for the treatment of narcolepsy? Out of these four, dexmedetomidine, modafinil, methylphenidate, and solriamfetol. Which medicine is the best medicine? Answer is modafinil. Very good. So modafinil is overall drug of choice for narcolepsy. Modafinil is overall drug of choice for narcolepsy. And who will tell me where we use methylphenidate as a drug of choice? Although we can use methylphenidate for narcolepsy also, but methylphenidate is a drug of choice for one condition, and it is mainly given to improve the attention span. Where it is mainly given to improve the attention span of a patient. So answer is ADHD. So methylphenidate is a drug of choice for ADHD. Modafinil is drug of choice for narcolepsy, and dexmedetomidine is one more drug that is given for ICU sedation. Right? Now guys, can I ask one difficult question again? So there is one difficult question. We call it complicated narcolepsy. So when the patient is having complicated narcolepsy, so complicated narcolepsy is known as cataplexy. Complicated narcolepsy is known as cataplexy. So in this complicated narcolepsy, the patient will started having the sudden sleep attacks. So patient will started having the sudden sleep attacks, plus the patient will also have the hallucination when the patient will get up from the sleep. So patient can have hallucinations when the patient will get up from the sleeping attack. Now who will tell me what is the best medicine for cataplexy? So complicated narcolepsy is known as cataplexy. What is the drug of choice for cataplexy? Cataplexy का drug of choice क्या है? Very good. So there are many students who have joined this lecture through YouTube, and even these people are answering correctly. So I'm so happy to see that you people know the answers. So cataplexy का drug of choice बता दो क्या है? What is the drug of choice for cataplexy? Very good. So Dr. Jigar, Dr. Dia, Zainab, all of you have given the correct answer. Answer is SNRIs. So SNRIs like venlafaxine. So venlafaxine is a medicine which is an antidepressant drug. This is given as a drug of choice for cataplexy. It's a complicated narcolepsy. So venlafaxine is a best medicine to be given for the treatment of cataplexy. This is all about question number 6. So question number 5, answer is C. Question number 6, answer is A. Now let's move on to question number 7. So if I talk about question number 7, which of the following is centrally acting alpha-2 agonist given as a muscle relaxant? So can you choose a drug which is muscle relaxant out of these four? So which medicine is muscle relaxant out of these four? Lofexidine, tizanidine, guanfacine, and bromocriptine. So the answer is tizanidine. So tizanidine is a drug which is a centrally acting muscle relaxant, and this medicine will again act on alpha-2 receptor. So this medicine will again act on alpha-2 receptor. So can you find out the common word in alpha 2 receptor medicines? So tizanidine is having the word dine. Even the dexmedetomidine is having the word dine. And if you go back to the previous question, the drug is clonidine. So clonidine, dexmedetomidine, and tizanidine, all these medicines are having the common word dine in their name, and all these medicines will act on alpha 2 receptor. They have the inhibitory actions in the body, can inhibit the muscle stretch reflex. So they can inhibit the muscle stretch reflex, and by inhibiting the muscle stretch reflex, these medicines, like this medicine, can be used as a muscle relaxant also. Right? So question number 7, answer is B, Bombay. Question number 8. So question number 8 is again based on cholinergic drugs. Again based on cholinergic drugs or autonomic system drugs. So what is the answer of question number 8? A 35-year-old patient, who is a known case of COPD. So patient is a known case of respiratory obstructive disease. Now this person has undergone an orthopedic surgery, and post-surgery he has a complaints of retention of urine. So he has a complaints of retention of urine. Now which of the following can be given as a most suitable drug for this patient treatment? So answer is, yes, answer is tamsulosin. So ideally the answer should be bethanechol over here, but bethanechol is a medicine. When given to a patient, one of the side effects of this medicine is bronchoconstriction. So this medicine can cause bronchoconstriction as a side effect, bethanechol. So we know that bethanechol is a cholinergic drug. So it's easy to find out from its name. The medicine name ends with the word chol. Bethanechol, the drug name ends with the word chol. It's a cholinergic drug. And any medicine which is a cholinergic drug can lead to some side effects, which we can remember by a mnemonic, that is dumbbells. So we know that all cholinergic drugs can cause diarrhea. All cholinergic drugs can result in urination. So these medicines can cause diarrhea, urination, meiosis, bronchospasm, bradycardia, lacrimation, salivation, and sweating. So all these cholinergic drugs can cause bronchospasm as a side effect. That is why in this question, the patient is already a known case of COPD, right? So we should not use bethanechol. It's better to use a drug which can relax the sphincter. So this medicine can relax the urinary sphincter. And because this medicine can relax the urinary sphincter, I can use this medicine for the patient who is suffering from retention of urine. So this medicine can relax the sphincter. I can use this medicine for treatment of retention of urine. The drug name is tamsulosin. Now this tamsulosin belongs to a class of alpha blocker. And alpha blocker is a topic which is very, very important for your exam. We have discussed already so many times, right? So we are discussing question number 8. We are discussing question number 8. And question number 8, the answer is tamsulosin. And this topic is based on alpha blockers. Now I would like to know about this tamsulosin. Who will tell me the mechanism of action of tamsulosin? Who will tell me the indications? Where do we use this medicine tamsulosin indication? And what are the side effects of tamsulosin? So 3 things you have to tell me about tamsulosin. Tamsulosin mechanism of action. Like this medicine particularly blocks which alpha receptor? So this we know it's an alpha blocker. But this is a blocker of which particular alpha receptor? So which particular alpha receptor is blocked by tamsulosin? What is the name of the receptor that is blocked by tamsulosin? What are the various indications? Where do we use tamsulosin as a drug? And what can be the side effect of this medicine? Very good. So this medicine is alpha 1 blocker, but I want a more precise answer. It's a blocker of which receptor? Answer is alpha 1A receptor. So this is a blocker of alpha 1A receptor. So Arushi, we don't have alpha 1D receptor in human. In human body, we don't have alpha 1D. So just remember it like this way. This is a alpha 1A blocker. So this is alpha 1A blocker. Okay, don't remember alpha 1D because we don't have alpha 1D receptor in the body, right? So it's a alpha 1A receptor blocker. And when I give this medicine can relax the prostate gland, as well as this medicine can relax the urinary sphincter. So this medicine can relax the urinary sphincter. medicine can relax the prostate, and this medicine is a drug of choice for BPH. This medicine is drug of choice for BPH, that we already know, right? So this medicine is drug of choice for BPH. Number two, this medicine can be given for retention of urine. So whenever the patient is having the retention of urine, this medicine can be used. Number three, this medicine can be used to remove the stones. This medicine can be used to remove the stones from urethra. So if the patient is having stones in the urethra or obstructed at the bladder neck, this medicine can be given to remove the stones from the urethra. So three indications where we use the medicine. Now if we talk about the side effect of this medicine, for the side effect of tamsulosin, we can remember a mnemonic, that is fire. So we can remember this mnemonic fire. So here I can say FI stands for floppy iris syndrome. So this medicine can cause floppy iris syndrome as a side effect, and the medicine can also result in retrograde ejaculation. So medicine side effects are retrograde ejaculation. The medicine can also result in floppy iris syndrome. So floppy iris syndrome and retrograde ejaculation are two important side effects. Floppy iris syndrome is due to the meiosis. Floppy iris syndrome is due to meiosis, and RE is retrograde ejaculation, side effect of tamsulosin. Right? Now here you people have to solve one exercise. So I'll give you one exercise to do. You people have to answer me this question. So we will now discuss the treatment of BPH. So if we talk about the BPH, who will tell me which medicine is best medicine for dynamic component of BPH? Which medicine is best medicine for the static component of BPH? And which medicine is given to control the symptoms of BPH like urgency and lower urinary tract symptoms? You have to answer me the BPH treatment. We are going to discuss the treatment of benign prostate hyperplasia. Which medicine is best medicine for dynamic component? So for dynamic component, the best medicine is, which medicine is best for static component? Till that time, I will have a sip of water. Very good. So on YouTube, one student has answered already. Dr. Ashish Kumar Parida, sorry. Yes, Nilay Kumar also have given the correct answer. Right. So, please remember, for the dynamic component, we have discussed already tamsulosin. So, tamsulosin is the best medicine to be started over here. It's a alpha-1A blocker. And when you start this medicine, the patient will start getting relief in 2 weeks. So, within 2 weeks, the patient will start getting the relief. So, within 2 weeks, patient will start getting the symptomatic relief. And we have discussed the medicines like fire. Right? So, side effect of this medicine is fire, floppy iris syndrome, and retrograde ejaculation. Dynamic component means when the patient is not able to pass the urine. When the patient urine is not coming out, that's a dynamic component. Second is the patient prostate size is enlarged. So enlarged prostate is a static component, right? And urination is a dynamic component. So dynamic component best improved by tamsulosin. Static component is best improved by 5-alpha reductase inhibitor. So static component best improved by 5-alpha reductase inhibitors. So we have the two medicines with us. One is known as dutasteride. Second is known as finasteride. So dutasteride, finasteride are two medicines which end up with the word ride, and they are the reductase inhibitors. So these medicines are the reductase inhibitors. So these medicines are 5-alpha reductase inhibitors. They are the best medicine for the static component. Now these medicines are minimally given for 6 months. Medicines required minimum 6 months to show their effect. And one of the important side effects of this medicine is they can reduce the level of PSA. So they can reduce the level of prostate specific antigen. This is an important side effect because when the prostate specific antigen will not be increased, it is suppressed, you can miss the diagnosis of prostate cancer. You can miss the diagnosis of prostate cancer. So these medicines can reduce the level of PSA and you can miss the diagnosis of prostate cancer. So 5-alpha reductase inhibitors, whenever they are started, they are given minimum for 6 months. But before starting the treatment, you should check the PSA level. Then you should start the medicine. Now, who will tell me which medicine is given for the urgency and the lower urinary tract symptom? Which medicine can take care of the patient bladder urgency? So the best medicine is M3 blocker, or we can also give beta 3 agonist. Best medicines are, I will not say only one drug. So M3 blocker or beta 3 agonist I can use. Now who will tell me which medicine is beta 3 agonist? Which medicine is M3 blocker? Which medicine is beta 3 agonist? Which medicine is M3 blocker given for this overactive bladder? So this is the overactive bladder causing the urge again and again. So how we can stabilize this overactive bladder? Any drug you know that is beta 3 agonist or M3 blocker, you know. Okay, no problem. I will tell you. The name of the drug is Mirabegron. So Mirabegron is a drug. This is asked this time in your INA-CT exam. So this time in INA-CT 2023, they've asked this medicine Mirabegron. So Mirabegron is a drug. This is beta 3 agonist. This is overall a drug of choice for urge incontinence. This is overall a best medicine for urge incontinence in a patient. So this can stabilize the bladder, but this medicine has a problem of tachycardia and high blood pressure. So this medicine can increase the heart rate. Medicine can cause high blood pressure as a side effect. So I cannot give this medicine to a hypertensive patient. So Mirabegron cannot be given to hypertensive patient because the medicine can increase the heart rate. Medicine can increase the blood pressure. The drug name is Mirabegron. Now if we talk about M3 blockers, now among M3 blocker, the best medicine you will mark as a trospium. The best is trospium. The second best is already given by Dr. Achal, that is derifenacin. So first is trospium, the second best is derifenacin. So trospium and derifenacin are the medicines that I can use. Right? Now guys, why trospium is better than other drugs? Why trospium is better than other drugs? The reason is that trospium is the only drug which cannot cross the blood-brain barrier. In the group of M3 blocker, trospium is the only drug which will not cross the blood-brain barrier. And this medicine cannot cause an important side effect of the group, that is dementia. So all M3 blockers like derifenacin, solifenacin, tolterodine, oxybutynin, all these medicines can cross blood-brain barrier. These medicines can cause dementia as a side effect. But trospium is a drug that will not cause dementia. And after trospium, if you have to mark some drug, is derifenacin. Derifenacin will not cause dementia. I mean, minimally cause dementia. But trospium is a drug that is made, that is discovered just because of this problem, that it will not cause dementia as a side effect. Very good. So all of you have given the correct answer. Achal has given the correct answer that it will not cross blood-brain barrier. And Jigar also has answered the correctly. It will not cross blood-brain barrier. The advantage is this will not cause dementia. So this is the treatment of BPH that we have discussed. Now let's move on to the next question. So this is the one we have discussed. Now the next is, what is the pressor agent of choice for hypotension that is seen after spinal anesthesia? So after spinal anesthesia, if the patient develops hypotension, so spinal anesthesia is very commonly given for LSCS surgery. So for LSCS surgery, lower segment cesarean section. So during this spinal anesthesia, that is very commonly given for LSCS surgery or the obstetric surgery, if the female develops hypotension, which vasopressor? What is the vasopressor of choice? What is the vasopressor of choice for this hypotension? So what is the vasopressor of choice for hypotension after obstetric surgery? So after obstetric surgery, which medicine is a vasopressor of choice? The answer is phenylephrine. Correct answer. So phenylephrine is a medicine. Phenylephrine is a medicine which is alpha-1 agonist. This medicine is alpha-1 agonist, and because this medicine is alpha-1 agonist, this medicine will increase the blood pressure due to the vasoconstriction. So phenylephrine is a medicine that will cause vasoconstriction. Due to the vasoconstriction, this medicine can cause high blood pressure and can control this hypotension. Right? But there is a one problem with phenylephrine. The problem with phenylephrine is this medicine can cause reflex bradycardia as a side effect. So this medicine can cause reflex bradycardia as a side effect. So due to this vasoconstriction, the medicine can cause reflex bradycardia as a side effect. Now after spinal anesthesia, not only the BP that is reduced, sometimes what happens, the heart rate is also reduced. So this is the main problem. Here is a click, right? When we give spinal anesthesia, there is a possibility local anesthetics that you have given during spinal anesthesia, these local anesthetics can go upwards. And when they go upwards, they can block the sympathetic nerves which are supplying the heart. And female can develop bradycardia along with the low BP. So the female is having low heart rate, female is having bradycardia along with low BP. Now in this case, phenylephrine is not a good option to be chosen. The reason is the medicine can cause reflex bradycardia as a side effect. So here we prefer to use a drug known as ephedrine. So in spinal anesthesia, if the patient is only having the hypotension, you will give phenylephrine. But along with the hypotension, if the patient is having bradycardia also, and that is quite commonly seen because you have given the spinal anesthesia drugs. So when these medicines are given in higher dose, this can cause hypotension, and when they are ascend upwards, they can affect the heart rate also. So in patients of hypotension with bradycardia, ephedrine is marked as a drug of choice. But for female only hypotension without bradycardia, phenylephrine is overall the best medicine. Right? So here you people can answer me few questions. So there's an exercise for you people, you have to answer me. Like if I go back, I can ask you to answer me this question. Okay, so whenever the question is asked, what is the drug of choice for acute hypotension? Who will tell me the drug of choice for acute hypotension? So drug of choice for acute hypotension, we are going to discuss the treatment of hypotension. So drug of choice for acute hypotension is always noradrenaline. So drug of choice for acute hypotension is always noradrenaline. Now for chronic and the orthostatic hypotension, you will mark fludrocortisone. So fludrocortisone is marked as a drug of choice for chronic hypotension. And if fludrocortisone is not given in MCQ, you can also mark midodrine and droxidopa. So you can also mark midodrine and droxidopa as a second drug of choice. So for chronic hypotension, the best medicine is fludrocortisone. The other medicines or the second drug of choice you can mark as a midodrine and droxidopa. But for acute hypotension, always mark noradrenaline. And for spinal anesthesia, we have discussed already. If the heart rate is normal or it is increased, you will mark phenylephrine. So here you will mark phenylephrine. But if the heart rate is down, you will mark ephedrine. So if the heart rate is down, you will mark ephedrine. If the heart rate is more or it's normal, you will mark phenylephrine. So these are the three questions which can be asked in relation to only hypotension. But as such, hypotension is a less important topic for your exam. Generally, they don't put questions on hypotension. Now, one student is asking about the medicines which are given for bladder incontinence. So here we can discuss the urinary incontinence. So urinary incontinence can be of three types. So we have the overflow incontinence, which is also known as atonic bladder. We have the urge incontinence, which is known as overactive bladder. And we have a stress incontinence. Now, whenever the question will come to you on the overflow incontinence or the atonic bladder, you will mark bethanechol. Is overall drug of choice. So bethanechol starts with B. This will cause contraction of the bladder. And we have discussed already the important side effect of this medicine is bronchoconstriction. Now for urge incontinence, there is a tie between two groups. There are two groups which are wonderful groups. So we have a drug like M3. We have a drug which is beta 3 agonist. Like mirabegron. So mirabegron is a medicine that we can use. And the second medicine is M3 blocker, that is trospium, that we can use. So both medicines are almost equally effective. Both medicines are almost equally effective, but you have to choose the medicine depends on the patient criteria. Like if the patient is old, patient will have the risk of dementia. Patient will have the risk of dementia. Patient will have the anticholinergic side effect in the body. Patient will have the dry mouth, dry eyes, or the constipation. So according to the anticholinergic side effect profile or the dementia risk, you will choose mirabegron. But if the patient is having more heart rate or more BP, you will choose trospium. So both medicines are equally effective. But again, you will ask me, sir, out of these two, can you choose one? So I would go for mirabegron. So out of these two, although there is no clear-cut answer, no textbook will support mirabegron or other will support trospium. But still, if you ask me, sir, which is the best medicine to be chosen, I will say mirabegron will be the better answer than the trospium. Now for the stress incontinence, you will mark duloxetine. So duloxetine is an SNRI. This medicine can be used for the treatment of stress incontinence. So for stress incontinence, you will mark duloxetine as a best medicine. This is for the urinary incontinence that we people have discussed. Right? So this is all about this question. Question number 9. Right? Now, after this question number 9, we can discuss few more points. Then we'll take a break. So if you go to the question number, so autonomic nervous system, one-liner MCQs we have covered. Now we are moving on to the multiple choice INSCT type questions. So who will answer me question number 50? So in question number 50, you have to choose the answer which can be more than one, more than one can be the correct answer. So what is the answer of question number 50? Contraindication for the use of beta blocker. What are the contraindications for the use of beta blocker? Anyone? So contraindications for the use of beta blocker. So beta blockers should not be given in patients of acute CHF. So in patients of acute CHF, the cardiac output is already low and beta blockers will reduce this cardiac output further. So this is a contraindication. Now beta blockers can slow down the conduction. So beta blockers can slow down the conduction in the heart, and because they can slow down the conduction in the heart, so they are contraindicated. They are contraindicated if the PR interval is more than 0.24 second. So if the patient PR interval, P means the atrial contraction, the R means the ventricle contraction. P means the atrial contraction, the R means the ventricle contraction. So the time gap between P and R is more than 0.24. These medicines are contraindicated. So here it is given less than 2. So that's why it is not a correct answer to be marked. Basically it should be millisecond. Although it's given as second, it's millisecond basically. Bronchial asthma, yes. So in bronchial asthma, generation 1 medicines. So generation 1 medicines are contraindicated in bronchial asthma. And for HOCM, the drug of choice for HOCM are beta blockers. So beta blockers are the drug of choice for the treatment of HOCM. So generation 1 medicines are contraindicated in bronchial asthma. So question number 50, answer is A and C, both are correct. So answer is B. So if you go with the key which is given above, answer is B, Bombay. Now guys, please tell me one question here which is asked this year in your INSCT exam. So INSCT 2023 exam, please tell me betoxolol belongs to which class? Betoxolol belongs to which class? This is the question asked this time in your INSCT exam. Betoxolol belongs to which class? No one can answer? No problem at all. I will answer. If you cannot answer, I will answer. So betoxolol belongs to which generation of beta blocker? Generation 1, 2 or 3? Very good. So betoxolol is a cardioselective beta blocker. It belongs to generation 2. It belongs to generation 2. It's a cardioselective beta blocker. It means it's a blocker of only and only beta 1 receptor. It is a blocker of only and only beta 1 receptor. So mera background is beta 3 receptor agonist, right? And this is mera background is asked, betoxolol is asked. Now let's move on to question number 51. Now question number 51, what is the answer? Betoxolol is generation 2. Generation 3 is bisoprolol. You people are getting confused with betoxolol and bisoprolol. Betoxolol the cardioselective hai, beta 1 blocker. This is what you have to remember. Question number 51. All are side effects of salbutamol. All are side effects of salbutamol. Anyone? Which of the following are the side effects of salbutamol? Anyone would like to answer? So salbutamol will not cause hypoglycemia. Rather, salbutamol can cause hyperglycemia. So salbutamol side effect is hyperglycemia. It will cause hypokalemia. Yes. So salbutamol can stimulate sodium potassium ATPase pump. Salbutamol can stimulate sodium potassium ATPase pump, can shift potassium inside the cell. So it is a side effect. So salbutamol will not cause dyskinesia. Rather, salbutamol will cause tremors. Instead of dyskinesia, salbutamol will cause tremors. One more side effect of salbutamol is tachycardia. So B and D are correct. So answer is C. So B and D are correct here. So please remember, the side effects of salbutamol are very important for your exam. You should be knowing the side effects of salbutamol. So for side effects of salbutamol, please remember this mnemonic. The mnemonic is 3T4H. Mnemonic is 3T4H, where the T stands for tachycardia, tremors and tolerance. T stands for tachycardia, tolerance, tachycardia, tremors and tolerance. The tolerance is very fast to develop. We also call it tachyphylaxis. Right? So T stands for tachycardia, T stands for tremors, T stands for tolerance or tachyphylaxis. Now H stands for what? H stands for hypokalemia, H stands for hypoxia, H stands for hypotension. So salbutamol can cause hypotension, hypoxia, hypokalemia and can result in hyperglycemia. So glucose level is increased, rest of the things you can find out are decreased. So hypokalemia, hypoxia, hypotension and hyperglycemia is a side effect of salbutamol. Now we can also discuss question number 52 if you want. So question number 52, nitric oxide donors. So which medicines are nitric oxide donor? Any medicine which has the word nitro in its name. So any medicine which has the word nitro in its name is a nitric oxide donor. So here the answer is nitroglycerin, nitroprusside, amyl nitrite. So any medicine which can donate nitric oxide is a nitric oxide donor. Hydralazine is a drug. This medicine is a nitric oxide inducer. So this medicine, hydralazine, by inducing the nitric oxide synthase enzyme, this will induce the nitric oxide. So this medicine will induce the nitric oxide. It's not a donor. Donors are those medicines which have the nitro or nitric oxide present in their name. So ABC is the best answer. So the answer is A. So question 52, answer is A. Right? So question 52 we have discussed. Answer is A, B and C. Right? Now let's move on to the next question. Now who will tell me the question number 55? What is the answer of question number 55? Atropine is used in organophosphorus poisoning. Atropine is used in organophosphorus poisoning. Question 55. Atropine is used in organophosphorus poisoning. Atropine can reverse the muscle weakness in OP poisoning. So the answer is, the assertion is correct and even the statement which is given in reason is also correct. but it is not the correct explanation of the A, right? So answer is B. So question 55, answer is B. So we know that whenever the patient has OP poisoning, so during OP poisoning, acetylcholine level is raised, and this acetylcholine can act on muscarinic receptor, and by acting on muscarinic receptor, acetylcholine can cause symptoms which can be remembered with the help of a mnemonic dumbbells, and this is the reason for death. So dumbbells is the reason for the death. Now acetylcholine will also act on the NM receptor. Acetylcholine, which is raised in OP poisoning, is also increased, also act on NM receptor. Now when this NM receptor is overstimulated, this results in down regulation of the NM receptor. So this results in down regulation of the NM receptor, and patient will come to you with muscle weakness. So patient of OP poisoning comes to you with muscle weakness because the excessive acetylcholine, which is acting on NM receptor, because of continuous stimulation of NM receptor, there's a down regulation of the receptor and can result in muscle weakness. And because of muscarinic receptor, the patient can develop the symptoms like E stands for epilepsy, one of the reason for mortality. Patient develops the bradycardia, one more reason for mortality. Patient develops loss of secretions, can lead to electrolyte imbalance, one more reason for death. Now whenever we give atropine is the drug which is blocker of muscarinic receptor. So this medicine can control the symptoms which can prevent the death, but it cannot act on this NM receptor. Atropine is muscarinic blocker, it's not a NM blocker, so it cannot control the muscle weakness. So this is the statement they have asked. It's not the correct explanation of assertion, right? Okay, now we can move on to the theme-based question. There is a one theme-based question I have put for you people. The medical management of pheochromocytoma. So who will tell me the medical management of pheochromocytoma? So whenever the patient of pheochromocytoma will come to you, first of all, you make the diagnosis. First of all, you make the diagnosis of pheochromocytoma. So nowadays, the diagnosis is made with the help of nuclear scan or with the help of urinary metabolites. So nowadays, the diagnosis is made with the help of nuclear scan, but in past, we used to make the diagnosis with the help of two medicine. One is phentolamine, second was clonidine. So clonidine and phentolamine were the two medicines. So clonidine and phentolamine were the two medicines which were used in history to make the diagnosis, but nowadays nobody uses this test. Now, once we made the diagnosis with the help of nuclear scans, now we have to go for the surgery. So pheochromocytoma, the best treatment is surgery. So best treatment of pheochromocytoma is surgery, that we already know. Now we cannot take the patient for surgery because the patient BP is high. So in pheochromocytoma, the patient BP is high and we cannot take the patient directly for surgery. So we have to bring this BP back to the normal or maybe in a controlled limit so that we can take the patient for surgery. Now, which medicine is the best medicine to control the hypertensive crisis in a pre-operative stage? So in a pre-operative stage, phenoxybenzamine. Phenoxybenzamine is a medicine that is the best medicine to be marked over here. It's a irreversible blocker. Why this medicine is a unique drug? Because it's a irreversible blocker of both alpha-1 and alpha-2 receptor. It's a irreversible blocker of both alpha-1 and alpha-2 receptor. So this medicine is the best medicine to be given in a pre-operative stage. This is given by the oral route. So patient को हम tablet देंगे, patient will take this tablet and we call the patient after few days when the BP is controlled and then we can take the patient for surgery. Right? Now, if we give phenoxybenzamine to a patient, now even then the BP is not controlled. So after giving phenoxybenzamine, if the patient BP is not controlled, can any one of you tell me which other medicine I can add by the oral route? Which other medicine I can add in the patient treatment to control this BP? So phenoxybenzamine is the best medicine to be given in pre-operative stages. No doubt the answer is correct. But if the pheochromocytoma BP is not controlled by phenoxybenzamine, if the BP is not controlled by phenoxybenzamine, which other medicine I can add in the patient treatment so that the BP will be controlled? Anyone would like to answer? It's a difficult question. The answer is me-tyrosine. So me-tyrosine is one more medicine which I can add in the patient treatment. So me-tyrosine is a drug which is tyrosine hydroxylase enzyme inhibitor. So tyrosine hydroxylase enzyme inhibitor. So this medicine I can add in the patient treatment to control this BP in a pre-operative stages. Phentolamine I cannot add because phentolamine there is no tablet. We have the parenteral preparation. So metyrosine is a medicine that is added in the patient treatment, and we call the patient after few days. Now when this patient will come to you, you will take the patient for surgery, and we know that during surgery, this pheochromocytoma can spill. This pheochromocytoma, the tumor will spill out this epinephrine and norepinephrine directly in plasma, and patient can develop intraoperative crisis. Right? So patient can develop intraoperative crisis. So patient can develop intraoperative crisis. So what is the best treatment for this intraoperative crisis? Anyone would like to answer? What is the best treatment for intraoperative crisis? So the answer we have discussed already. For any intraoperative crisis, we can give sodium nitroprusside. So sodium nitroprusside is the best treatment for any type of intraoperative crisis, including the pheochromocytoma. But if nitroprusside is not given in MCQ, in cases of pheochromocytoma, we can also use phentolamine. We can also use phentolamine for prevention of intraoperative crisis, but nitroprusside is the best medicine to be given. Now, whenever we give nitroprusside to a patient, this medicine has a problem. Like if the surgery has prolonged, if the patient's surgery is prolonged, this medicine can cause cyanide toxicity. So this medicine can cause cyanide toxicity as a side effect. So nitroprusside has a problem. If the pheochromocytoma surgery is prolonged, this medicine can cause cyanide toxicity. Now, as a surgeon, how will you observe that patient is developing the cyanide toxicity? So you will check the PO2 level. So you are performing the surgery, you are a surgeon, you will check the patient PO2 level. So when the patient PO2 level will start declining, it means the patient has started developing the cyanide toxicity. So when this PO2 level will start declining, immediately you have to give the antidote. You have to give the antidote to this patient, and the name of the antidote is hydroxycobalamin. So hydroxycobalamin is an antidote for the cyanide toxicity caused by the nitroprusside. So nitroprusside can cause cyanide toxicity. You need not to stop the surgery. You need not to discontinue the surgery. You have to give an antidote while doing the surgery. So hydroxycobalamin is given to prevent this cyanide toxicity. Right? Now out of this, question 69, which drug has no role in treatment of pheochromocytoma? So question 70 we have discussed already. Which drug is useful for diagnosis? So diagnosis के लिए जो drugs हैं, there are two drugs that were used in past. One was phentolamine, the second was clonidine, but nowadays we don't use this medicine, so this is an unimportant question. Question 69, you people have to answer me. Which drug has no role in treatment of pheochromocytoma? So the answer is generation 1 beta blocker. So generation 1 beta blockers can cause vasoconstriction. So generation 1 beta blockers can cause vasoconstriction. So they are contraindicated. They are contraindicated in patients of hypertensive crisis. So in patients of hypertensive crisis, these generation 1 medicines are contraindicated in pheochromocytoma. Now, here you people have to remember one concept. Here in pheochromocytoma, if I ask you this question, there's one question for you people. Before taking the break, I'm giving you one question to solve, and I'll discuss this question after coming back from the break. So if the patient is having pheochromocytoma, it's a difficult question. Patient is having pheochromocytoma. In patient body, the noradrenaline and the adrenaline level is high. So patient adrenaline and noradrenaline level is high, and they are acting on the beta receptor, causing the tachycardia or maybe the arrhythmia. And they are also acting on the alpha-1 receptor, causing the hypertensive crisis. So they can result in, the patient can have the hypertensive crisis because of alpha-1 receptor. Patient can have the tachycardia because of beta-1 receptor. Now, whenever I want to take this patient of pheochromocytoma for surgery, if I want to take this patient of pheochromocytoma for surgery, I have to control hypertensive crisis, I have to control tachycardia. Now, to control hypertensive crisis, I have to give alpha-1, I have to give alpha blocker. To control this hypertensive crisis, I have to give alpha blocker, but that alpha blocker should be the blocker of alpha-1, alpha-2 both. And to control this tachycardia, I have to give beta blocker. I have to give beta blocker. Now, who will tell me this question? Which medicine I will give first? Whether I will give beta blocker first or alpha blocker first. And here you have to answer me, what is the re-reversal of Dale? You have to answer me, what is the re-reversal of Dale? So reversal of Dale, you already know. So reversal of Dale, you already know. You have to answer me, what is re-reversal of Dale? Very good. So all of you have given the correct answer. First of all, we will give alpha blocker. So alpha blockers are always given as a first drug and beta blockers are always given as a second drug, and we always give generation 2 or 3 medicine. We never give generation 1 medicines. Generation 1 medicines are contraindicated. Generation 2 medicines are, generation 2, generation 3 medicines are indicated. Now who will tell me what is re-reversal of Dale? Re-reversal of Dale, बताओ, ये वही है, whatever we have discussed is re-reversal of Dale. So whatever we have discussed so far is re-reversal of Dale. So what is re-reversal of Dale? If beta blocker is given, if beta blocker is given, if beta blocker is given in high dose of, with high level of adrenaline and noradrenaline. If beta blocker is given with high level of adrenaline and the noradrenaline, patient will have the rebound hypertension crisis. Patient will develop rebound hypertension crisis. So never ever give beta blocker. Never ever give beta blockers without giving alpha blocker. Otherwise, what will happen? This adrenaline will start acting on alpha 1 receptor and can result in rebound hypertensive crisis. This is very, very important question for understand for your exam. So this is all about the questions asked on ANS. So in this short session of 2 hours 20 minutes, we have discussed about the ANS topic. Around 16-17 MCQ we have discussed based on autonomic nervous system, right? So after this break, we will start with other topics. Like other topics are respiratory system, kidney. So today we'll try to finish kidney and CVS. In next session, I will finish kidney and CVS. And tomorrow I will take general pharma, the rest of the topics like general pharma, GIT and autocoids, right? So today we'll try to finish kidney and CVS till 9. Okay. So guys, take care of yourself. Enjoy your tea, have some good tea, have some coffee, have some cold drink or something else, whatever you want to have, right? Don't think about studies for this 15-20 minutes. Enjoy your break.